and completed his fellowship in endocrinology, diabetes and metabolism at the University of California, San Diego. He has held academic position at the University of Colorado Health Sciences Center and the University of California, San Diego School of Medicine. He has been involved in diabetes, obesity, metabolic liver disease, and other metabolic-related research for over 30 years, and has authored numerous publications in his field, including first author publications in New England Journal of Medicine, Lancet, and Lancet Diabetes Endocrinology, and Diabetes Care. Dr. Farias today will highlight and enlighten us about the de-intensification arm.
And I'm going to share my screen here. Hopefully, let's see if we can make it bigger. Hopefully you can see that.
Yeah, we can see it. Yeah, we can see it. But put it full screen.
We can see
full screen. We should be ready to roll. Good, good. Yeah. So this I think is a super important topic, and something we certainly see in clinic a lot these days is people coming in with very complex insulin regimens, yet with very poor control. And at the end of the day, when we speak to them, there are just so many barriers for them being able to even adhere to these therapies, or they're having issues with weight gain or hypoglycemia. That truly, these patients oftentimes, benefit greatly by a simplification or a de-intensification of their therapy, so that they could actually take it. And what I'm going to be talking about is the de-intensification of insulin therapy, particularly patients who are on basal bolus or basal plus regimens of insulin, or premix regimens, particularly twice daily premix regimens, and the advantages we've seen in clinical trials of, in the properly selected patient, of de-escalating therapy or de-intensifying therapy with a fixed ratio combination. And in this case, with iglar-lixi, or the fixed ratio combination of insulin glargine with the GLP-1 receptor agonist lixisenatide. So here are my disclosures. And, by way of background, and this well, I mean, certainly we see, if you look at the top left here, many patients with type 2 diabetes, unfortunately, aren't diagnosed. In the US, it's estimated to be around 30%. And when we go do health screenings, we find many patients who've had type 2 diabetes for years are completely asymptomatic with very high glucoses. Of those that are diagnosed, the majority are treated. In this particular trial, it was around 90%. But unfortunately, the vast majority are not achieving adequate glycemic targets, and then have the burden, not only of kind of the psychological and social burden, but also the burden of micro and macrovascular complications. And this really does decrease quality of life. And if we look at all of the guidelines, what is our goal of therapy? Really is to improve, one of the key goals is to improve the quality of life of the patient as well. If we look now particularly at complex insulin regimens, and what's shown here in this particular study, that over 75% of patients on very complex insulin regimens, basal bolus in particular, but also premix, over 75% not achieving adequate glycemic control. This increases, as you see in the middle, increases risk of complications. And these are some of the data from your country, from Saudi Arabia, just showing the increased risk of both micro and macrovascular complications. And as we're considering intensification of therapy in patients who need additional glycemic control, there's certainly many considerations, and considerations for the healthcare provider. Will the patient adhere? Will there be good persistence? How am I going to intensify or escalate or titrate the insulin once I initiate? That's a huge problem we have here, particularly in the primary care clinics. If patients are started on a basal insulin or basal bolus, and then their doses are just never changed. What are some of the multimorbidities or complications that the patients have that would influence our choice of therapies? And then adverse events as well, particularly hypoglycemia, but also weight gain. And from a patient perspective, certainly the hypoglycemia, weight gain, the regimen complexity, and oftentimes the lack of support to make the proper insulin dose titrations become very important issues. And clearly there's an increased treatment burden, particularly as we go to more complex insulin regimens. So either perceived or I would say real complexity, the potential need for calorie counting with a basal bolus, and these just multiple daily injections that oftentimes patients just simply can't take. So, if you look at the bottom bullet there, so simple, more effective advancement options are needed to help overcome these challenges. Now, our main discussion here, though, is going to be about de-intensification. I think this study makes a lot of sense, which is just basically the more injections a patient has to take, the lower their adherence. And this was a particular systematic review of 76 studies showing this quite obvious point, I think, but it's nice to see the data. And if you look at the graphic on the bottom right, you see that patients with one injection a day showed about 80% adherence as it was defined in the study, and the adherence declined with the increased number of injections being about 50% with 4 injections daily. And I would say that is actually pretty good. In my practice, I would say it's probably even lower than that, quite frankly. This was a study of over 48 weeks that showed patients going on basal plus, so basal insulin with a 1 prandial injection, and also patients on premixed insulin. And what's illustrated here is just the high relative risk of hypoglycemia with these regimens. So in this particular study of 48 weeks, over 60% of patients experienced hypoglycemia during the 48-week period. And then also weight gain, as you know well, with up to 4 kilogram weight gain after initiating one of these more complex insulin regimens, 2.3 kilos with premix and 4 kilograms with basal bolus. And patients obviously are concerned as well. When we ask patients, in this particular study, but this is very consistent when you look at the literature, what are their biggest concerns, particularly when they're on a basal bolus regimen? And again, it ends up being weight gain, being by far the most common concern, but also hypoglycemia, difficulty adhering to such intensive therapy, and feeling that the intensified regimen is just too complicated for them. So that becomes a key issue. This was actually a study done in Saudi Arabia in people on basal bolus regimens, and it's very consistent with the data from the other studies. So that if you look at on the left there, the main self-reported reasons for non-adherence in these patients with a complex regimen was, they're away from home and they can't take all this stuff that they need to administer their therapy. They're having difficulty adhering to the diet. They're embarrassed to take an injection in public. There's no time to take is not appropriate. And so that's sort of very similar to embarrassed in public, I guess. They just simply forgot, or the regimen is too complex. And if you look on the right, again, the key barriers that come out are hypoglycemia and weight gain over 50% of the participants. So certainly simplifying treatment regimens is playing a much more important part in our guidelines today. And I think this is based on important, clinical evidence and what we see in our practices, but also some very good studies as well. So the importance of simplification. So maybe loosening goals for some patients if they don't need such tight control, for example, fewer drugs. Make the regimen possible for the patient. And then in patients with complications, and particularly if they have a lot of hypoglycemia or are having issues with weight gain. So what are some of the factors that we need to consider? And what does the patient look like that needs that potentially needs de-intensification of their therapy? So patients who are not adhering, so non-compliance, maybe they just stop it and they're not persistent, and this results in poor control. People with severe comorbidities that are at very high risk of hypoglycemia would make the regimen possible for the patient. And then in patients with complications, and particularly if they have a lot of hypoglycemia or are having issues with weight gain. So what are some of the factors that we need to consider? And what does the patient look like that potentially needs de-intensification of their therapy? So patients who are not adhering, so non-compliance, maybe they just stop it and they're not persistent, and this results in poor control. People with severe comorbidities that are at very high risk of hypoglycemia, whether this is chronic kidney disease or cardiovascular disease. Again, the severe and frequent episodes of hypo, which are such a barrier for patients and have them oftentimes lead to them de-intensifying on their own. And then patients who are afraid of continuing to gain weight with a very complex insulin regimen. In my practice, certainly we take all of these into consideration. And I also see quite a few patients that are the so-called SID category, or severe insulin deficient diabetes. It's not a small proportion of patients, particularly in my Asian patients, but in the white and Hispanic population and Black population as well. We see patients who are leaner patients with type 2 diabetes who need insulin therapy, but oftentimes they don't need that degree of complexity with a basal bolus regimen or premix regimen twice daily. So I'll move forward with that as background, that there are many patients that need de-intensification, and go through two studies which were recently published in Diabetes, Obesity, and Metabolism. So one of them is the IDEAL study. So this was a study in people already on basal bolus insulin therapy, so multiple daily injections, basal insulin and prandial insulin, who either continued their basal bolus therapy or were randomized to switch to Iglar-Lixi, the fixed ratio combination. Oh, sorry about that. And then the second study is the solely switch study. And this was a single arm study where patients were on premixed insulin, and the majority, about 90%, were taking it twice daily. So this is an insulin, as you know, with a basal and a prandial component together. And they were switched to Iglar-Lixi and also treated for 24 weeks. And in both of these studies, the primary endpoint was the change in hemoglobin A1c from baseline to the end of the study. So the first one is the so-called IDEAL study. And in the IDEAL study, the main objective was to evaluate the efficacy and safety of basal bolus insulin therapy versus de-intensification to once daily Iglar-Lixi in people with type 2 diabetes. So we wanted to look at the de-intensification from basal bolus. Again, this was a 24-week study, 5 centers. This is a phase 4 trial. And these were all people with type 2 diabetes on a basal bolus insulin regimen at baseline using less than 0.8 units per kilogram of insulin. And they were randomized, as you can see here in the graphic at the bottom, in a 1-to-1 fashion, either to switch to Iglar-Lixi or to continue their basal bolus insulin therapy for 24 weeks. And then there was a 12-week follow-up period. So during the active period, after they were randomized, the Iglar-Lixi and the basal insulin doses in the basal bolus regimen were titrated to reach a goal of 6 millimolar, or less than 6, I should say, so less than 108 milligrams per deciliter. There was CGM conducted before and at the end of the trial. And as I mentioned before, the primary endpoint was change in A1c, but some very important secondary endpoints. So the change in body weight, the total daily insulin dose, fasting and postprandial glucose, and importantly, the frequency of hypoglycemia. This is kind of busy, but I would just focus on the total. The baseline characteristics were well matched between the Iglar-Lixi patients, which was 45 patients, and those that continued MDI or basal bolus. And you can see the mean age was around 66. So these are patients who were already on basal bolus. They always tend to be a bit older in all the trials, so 66 on average. Very few females, actually. It was mostly men, so 22% were females. The BMI, these were on average obese patients with a BMI of around 34. A1c, poor control, 8%, but not terrible, but 8% on average. The majority of patients were on metformin, about 80%, and about half of the patients were also on an SGLT2 inhibitor, and they continued those medicines through the trial. You can see the most of the patients, if you look on the right, were on analog basal insulin, so either degludec, detamir, or insulin glargine U100 or 300. Almost all of them, actually. Only 1% were on MPH insulin, so that's nice. And then the majority were on prandial insulin analogs, 91%. And the total daily insulin dose at baseline was around 60 units, 60 units. So this is important because this is the transition from a patient on basal bolus to iGlarlixy. And it was based on the basal insulin dose at baseline. So you can see in the graphic here, if the basal insulin dose was 10 to 20 units a day, they would use the 150 pen. Okay, so that is the so-called peach pen, which is the 2-to-1 pen, which contained, for every 100 units of insulin glargine, there are 50 micrograms of lixisenatide. So if they were on 10 to 20 units of basal insulin, they would just basically either go whatever their dose was, 10 to 20 dose steps of the so-called peach pen. If they were on 20 to 30 units, they initiated with the 20 dose step. So that's 20 units of insulin glargine and 10 micrograms of lixisenatide. And this is one injection a day, and it was given before breakfast within 60 minutes prior to the breakfast. If they were on a higher basal insulin dose at baseline, so 30 to 60 units, they would initiate with 30 dose steps of the 133 pen, which is the so-called olive pen. Okay, so that dose is 30 units of insulin glargine and 10 micrograms of lixisenatide. So we never can start this with higher than 10 micrograms of lixisenatide. So quite easy. 10 to 20 units of basal insulin, you would just start anywhere between 10 and 20 dose steps. With the peach pen, 20 to 30 units of basal insulin before the switch, starting with 20 units using, again, the peach pen, and then over 30 units, 30 to 60, 30 dose steps of the so-called olive pen, so the 133 pen. With respect to the prandial insulin, if the prandial insulin dose was 8 units or lower, it was just stopped. If the prandial insulin dose at any given meal, and we'll go through an example in the next slide, exceeded 8 units, then it was reduced by 50%. So it was halved at the time that iGlarlixy was initiated, and then it was discontinued in the following 2 weeks. And again, as I mentioned, the iGlarlixy then, or the basal insulin in the basal bolus regimen, was titrated for a fasting glucose of less than 108 milligrams per deciliter. So here's an example from this trial. So we have a patient who's on a basal bolus insulin regimen. Their total daily insulin dose is 61 units, and their insulin glargine dose in this case, or it could be any basal insulin, is 37 units. And then they happen to be on glulisine as their prandial insulin, and it's 24 units divided into 3 injections a day. So what should the starting dose of iGlarlixy be in this patient? And the answer is that it should be 30 dose steps. So again, if anyone is on over 30 units of basal insulin, they would start with the olive pen, 30 dose steps, which is the 3-to-1 pen, which is 30 units of insulin glargine and 10 micrograms of lixisenatide. How about the prandial insulin? So this patient happened to be on 4 units before breakfast, 10 units before lunch, and 10 units before dinner. And remember, if they're on less than 8 units, it was just stopped. If it was greater than 8 units, it was halved. So the breakfast would just be stopped. The lunch would be reduced to 5 units and then in 2 weeks stopped. And then the dinner also 10 units in 2 weeks stopped. Clearly, we need to, be looking at the patient's self-monitored glucose and managing this as we make the transition. But this was what was done in the study and worked out quite nicely. So if we look at the main results now at 24 weeks, there was a similar improvement on the far left in hemoglobin A1c, slightly in favor of Iglar-Lixi, but basically the same. It was a 0.47% reduction in A1c with Iglar-Lixi and a 0.37% reduction in A1c in the basal bolus group. You also saw very similar improvements in fasting glucose and postprandial glucose. But if you look on the right, always in favor of Iglar-Lixi, but basically I would just say similar glycemic control with one regimen that's 1 injection a day versus a regimen that's 4 injections a day. I think where we really see the advantage here is that despite, we have similar glucose control, but with significantly lower insulin dose. So if we look at week 24, the total daily insulin dose was almost 30 units lower with Iglar-Lixi, you can see here, compared to the basal bolus. With the basal bolus, it was a small increase in insulin dose. With Iglar-Lixi, there was a significant reduction in insulin dose. And there was also a significant reduction in body weight. If you look at the treatment difference at week 24, was over 4 kilogram improvement in body weight with Iglar-Lixi compared to the basal bolus regimen the patients were continued, that they were on a baseline and then continued. We also looked at they also looked, I should say, at the proportion of visits during which hypoglycemia was reported, and this was significantly lower with Iglar-Lixi compared to the basal bolus insulin therapy arm. And then also various measures of patient-reported outcomes, so of quality of life. And this would happen to be the Diabetes Treatment Satisfaction Questionnaire. And you can really see improvements in all of the domains. And then at the end there, the whole treatment satisfaction score significantly greater with Iglar-Lixi compared to MDI or multiple daily injections or the basal bolus insulin therapy. So to summarize this study, insulin therapy de-intensification from basal bolus insulin therapy regimen to Iglar-Lixi was shown to be safe and effective, comparable glycemic control, so nice reductions in A1c, but similar to basal bolus, but with a reduction in body weight, lower total daily insulin dose by almost 30 units, far fewer injections, 1 a day versus 4 a day, lower proportion of visits in which hypoglycemia was reported by the patient, and improved quality of life, which we would think over time in the real world would result in better adherence and persistence with the therapy that can just be taken at home. I mean, we saw before some of the key barriers in that study in Saudi Arabia were just embarrassment about taking the injection, the time of the injections, not being at home to take the injection. So it's very difficult for patients to comply with a regimen like that. The second study I'll show is the solely switch study. So this was a different population of baseline. Rather than basal bolus, these were patients on pre-mixed insulins at baseline who were then switched, to Iglar-Lixi. So this was a single-arm study, so no control group. 24 weeks. And again, patients at baseline, you can see the population there. These were adults with type 2 diabetes, not achieving glycemic targets, on pre-mixed insulin, and again, 90% twice daily with 1 or 2 oral agents. And then you see the BMI there. And they were basically switched, and they were treated for 24 weeks. The primary endpoint shown on the left was a change in hemoglobin A1c, and then key secondary endpoints were the proportion of patients achieving an A1c of less than 7%, and then some composite endpoints, achieving less than 7% without clinically significant, so level 2 or level 3 hypoglycemia, and less than 7% without clinically significant hypoglycemia and without any increase in body weight. That shouldn't be changes in body weight. That should be without increase in body weight. And also other endpoints would be the obviously the safety, so hypoglycemia, but also the total daily insulin dose, fasting, postprandial glucose, and importantly, body weight. These are the baseline characteristics. Again, these tended to be older patients, on average age of 65. The majority, again, were male patients, 89% were male. Body weight, 80 kilos. BMI is not shown on this slide, but these patients were generally obese, on average anywhere overweight. Duration of diabetes quite long, 16 years. Baseline A1c very poorly controlled, 8.5 on average. As I mentioned before, the BID premix in about 90%. And you can see that the premix total dose was 38 units on average. And then the starting dose of Iglar-Lixi in this case was based on a 20% reduction of the previous total daily premix dose. So basically, you just added up all of the insulin dose for the day, divided it or reduced it by 20%, and that was the basis of the starting dose of Iglar-Lixi. Here we see the key results. So from before to after, again, an A1c of 8.5, there was a 1.2% reduction in A1c over the 24 weeks to 7.3%. So very nice reduction in A1c. There was also a reduction in fasting glucose. You can see about a 46 milligram per deciliter mean reduction in fasting glucose. That's the glucose sent to the lab. Also with the self-monitored glucose, there was very consistent of 50 milligram per deciliter reduction, and very nice reductions in postprandial glucose. So 68 milligrams per deciliter. And again, as you know, lixisenatide is a short-acting GLP-1 receptor agonist that does have a very profound effect on post-meal glucose, as can be seen here. So this in purple at the top, this is a 7-point glucose profile, so self-monitor profile throughout the day, baseline at the top, and then you see, so that's on the premixed insulin, almost all of it twice daily. And then you see these very nice reductions, not only in fasting glucose, but in the postprandial glucose excursions. And the mean glucose was improved significantly as well. With respect to body weight, despite the fact that there was a 1.2% decrease in hemoglobin A1c, so significant improvement in glucose, there was actually a reduction in body weight, on average 1 kilogram. And the insulin dose really was changed very little. So it was not reduced, but certainly it was very similar. It was 38 on average with the premixed insulin twice daily, and 40 on average with the, or 41 on average with the Iglar-Lixi at the end of 24 weeks. If we look now at the categorical variables, so the 82% were the proportion of patients at 24 weeks that had some improvement in glucose control. So 80% had some improvement, which is nice. 40% or 38% achieved an A1c of less than 7%. And again, the mean A1c at the end of the 24 weeks was 7.2, starting from 8.5. And then almost a third, so 30%, had an A1c of less than 7% without clinically significant hypoglycemia. And then about 1 in 5 or 22% had sort of the triple composite of A1c less than 7, no hypoglycemia, and no body weight gain. If we look at the hypoglycemia, again, we don't have a comparator arm, but this is very consistent with what's seen in the literature, and it's quite low, as you can see. I mean, first of all, no level 3, so no severe hypoglycemia, despite these patients being patients who've been, had on average diabetes for over 15 years and had a 1.2% reduction in A1c with Iglar-Lixi, and then very little level 2. Hypoglycemia, or less than 54 milligrams per deciliter. So less than 1 event per patient per year. And then I think an acceptable event rate of 3 events per patient per year of level 1, or less than 70 milligrams per deciliter. But importantly, no severe hypoglycemia. A post-hoc analysis, or an analysis, I should say, that was done, we looked at baseline characteristics, and you can see on the left there and the effect on A1c. So irrespective of the baseline A1c, there were some very nice reductions. So in those patients, for example, with a baseline A1c of less than 8%, you saw they went from 7.7 to 6.9 on average. But even in those patients with an A1c of greater than 9%, they started at 9.4. You can see they had a 1.7% reduction in A1c and came down to 7.7. So very nice reductions to less than 8. And that's at 24 weeks. And certainly those are patients that in our practice, maybe we could dose titrate a bit more. Age didn't seem to matter as well, whether the patients were less or over 65. And as you recall, on average, they were around 65 years old. Duration of diabetes as well, whether it was less than 10 years or over 10 years. So even in those patients with a very long duration, they had a 1.2% reduction in A1c. And also SGLT2 inhibitor use. I don't recall exactly, I think it was 45% were on SGLT2 inhibitor, but whether they were on an SGLT2 inhibitor or not, they had a nice reduction in A1c. And patient-reported outcomes as well. This is the TRIM-D score. So if we look sort of across the domains in red, you saw improvements from baseline. Again, there's no comparator here, from baseline to week 24 in the total score, which is shown in the far left. And then you can certainly see treatment burden went up significantly. Diabetes management went up as well, compliance and psychological health. So nice trend in the right direction with all of these, including the overall score. So summary and conclusion of the SOLI switch study is a switching from premixed insulin to iglorlixi resulted in simplification of the treatment regimen and significantly improved the glycemic control in patients with type 2 diabetes who at baseline were on premixed insulin, producing a beneficial effect on body weight without a clinically significant increase in hypoglycemia. I would also add with a significant improvement in measures of quality of life, which again, I think is critically important for this to translate into real world effectiveness. So this is my final slide. So the summary is that the progression of type 2 diabetes and its demanding treatment requirements often diminish a patient's quality of life, and improving their quality of life is one of our key goals in treatment. Complex insulin regimens increase treatment burden, frequently leading to poor medication adherence and issues with persistence and suboptimal glycemic control. We saw in the one study that 75% of patients with these complex insulin regimens are not achieving target, and that's probably what we all see in clinic too. Treatment de-intensification should be considered for patients who struggle with adherence. That's the main reason I generally do it. Experience frequent hypoglycemia or have significant comorbidities, and maybe don't need an A1c of less than 7% as well. Switching to iglorlixi from either multiple daily injections, so basal bolus insulin therapy, or premixed regimens, as we saw in the SOLI switch study, improves quality of life by reducing treatment burden, significantly less injections, and they can all be done at home before breakfast, while enhancing hemoglobin A1c, lowering the risk of hypoglycemia, minimizing weight gain. I would add reducing the insulin dose and also improving not only fasting, but postprandial glucose. So with that, I thank you for your attention, and I think we have time for some questions.
Thank you, Dr. Bourias, for this really nice talk as usual. And I think it's a very important topic. Simplification of therapy is very vital role as a physicians dealing with patients with diabetes. The simplification is very important to management of diabetes.
I agree. And we're doing it more and more these days as we have more agents as well. I think it's kind of the basal bolus is still important therapy, certainly for type 1 diabetes and maybe for a small proportion of type 2s. But I think we have the sort of the tools and the drugs now to give patients more simple regimens that they can adhere to. I agree.
Sure. Just in the chat, I don't see comment or question, but I will go as we usually face in the practice. Always we get question from our colleagues in family medicine and others, our fellows. They said, can I add short-acting insulin in patient taking the fixed combination?
That's a good question. Yeah, and I would say absolutely. I mean, certainly in my practice, sort of now that we've had a chance to use it for so many years, generally it's given before breakfast, but oftentimes it's just the largest meal of the day, or if my patient doesn't eat breakfast, I'll take it at lunch. I certainly find that, let's just say they take it at breakfast, it really reduces the post-breakfast glucose. And that actually then leads into a lower pre-lunch glucose, which sort of helps the glucose throughout the day. But with that said, I mean, lixisenatide is very short acting, so it's not going to have the same effect as dinner. So if I'm finding that the bedtime glucose is very high as we're making adjustments, this could be a case where someone would just take a little bit of a prandial insulin, whether it's aspart or lispro or glulisine, whatever, with the dinner to just help lower the bedtime glucose a bit, and then would just have the fixed ratio combination with insulin glargine and lixisenatide at breakfast. So we could certainly do that. And I know, we were part of the early phase 3 trials, the so-called Lixiland trials, and that was used as sort of rescue in patients, particularly if they've reached the 60 dose step highest dose and still needed a bit more control. That was a way to do it. I use it very infrequently, but it certainly can be done.
Yeah, I agree because especially in Saudi, the culture is different, the meals different. Sometimes it's two big meals like lunch and dinner.
Right.
Sometimes there is a late dinner, so that's at least cover that part. Our colleagues always asking about.
Right.
The other one is
Dr. Fahd, Dr.
yes.
Fahd, there are questions in the Q&A.
Okay.
I can't see it. I'm going to the chat. Is there any
No, go
questions?
to the Q&A. There are 5 questions in the Q&A.
Q&A. Okay.
Oh, I see it here. I do see it. If
you do see it because
yeah. There's a Q question and answer.
Yeah.
Yeah. So one of them. Do you mind if I read them since I see them, or
Yeah,
can
yeah.
you?
Go ahead.
Yeah.
Go
So
ahead.
one of them is, how can I start switching my patient from premix? Is there a dosing guidance? And what was used in the trial was to add up all of the dose of the premix and then reduce by 20%. And quite frankly, I mean, I thought it was quite easy. If the absolute dose, then reducing by 20% was greater than 38 units, or no, I'm sorry, that was without the reduction. If the dose was greater than 38 units, they would just use the 30 to 60 pen, which is the olive pen, and start with 30 units, which is 30 units of insulin glargine and 10 micrograms of lixisenatide. So I mean, in my mind, usually if they're on over 40 units, I just use that. I would just go to the 3-to-1 pen or the olive pen and start with 30. And then if they're on, less than that, you would basically go with the 2-to-1 pen or the peach pen. And if they're on less than 25 units, you could just start with, anywhere between 10 and 20 or so. If they're on over 25 to 40 units, start with 20 units. But with that pen, the maximal starting dose is 20 units because that has 10 micrograms of lixisenatide. And with the 3060 pen, you would start with 30. So it really is based on the dose of premix they're on. Just to simplify it, I would say if they're on over 40 units, I would start on 20 or 30 units, I'm sorry, with the olive pen. If they're on less than 40 units, you could start with either 20 units or something lower of the 2-to-1 or the peach pen. So hopefully that's clear, but it's based on the amount of premix that they're using, and it is just stopping the premix and initiating the dose then of Iglar Lixi. What is your experience with reaching ceiling dose without achieving A1c target? And here the ceiling dose is the 60 unit dose with the olive pen, which has 60 units of insulin glargine and 20 micrograms, which is the maximal dose of lixisenatide. Most of my patients can do well if they're well selected. These patients were on less than 0.8 units of insulin per day. So if you have a patient with massive insulin doses and they're actually taking them and they're well over 60 units, maybe this isn't the right therapy. But certainly if they're close to or around 60 units and below, then I would certainly attempt this, because chances are they're not taking all that insulin anyway. Relatively few of my patients get to 60 without getting good control. But if they do, as we had talked about before, generally it's because they're having high bedtime glucoses, and that could be, just taking a little bit of prandial insulin. I shouldn't say a little bit, a dose of prandial insulin would be important. Let's see, any concerns with pancreatitis and retinopathy similar to long-acting GLP-1 receptor agonists? Yes, there is. There are plenty of data now that sort of refute that GLP-1s cause pancreatitis, but people with pancreatitis were not studied in these clinical trials. If patients have a history of unexplained pancreatitis, I'd be very careful. But and certainly with retinopathy, I mean, these agents lower the glucose quite quickly. So patients with unstable proliferative retinopathy, maculopathy, we should be careful with these drugs and be a little more ginger and reduce their glucose less quickly in those patients. So we always need to know the retinal status of our patients. And it's not due to the lixisenatide or to the GLP-1 receptor agonist or GIP-GLP-1. It's really due to the rapidity of the reduction in glucose in someone with unstable retinopathy. Question here. So if one injection using Soliqua can cover multiple meals in a day, especially compared to basal bolus, can you elaborate on what the mechanism is behind it? Yeah, that's interesting, because I think it's what I had mentioned before. I mean, certainly at the time the injection is given, the meal before which it's given, the lixisenatide is having the main amount of action, and that's where you see the greatest. If you looked at that 7-point profile I showed, the greatest reduction in postprandial glucose. But I do find that as the day goes on, I mean, they start given the effect at breakfast of lixisenatide and then the effect throughout the day of the insulin glargine, they start the next pre-meal much lower, which certainly helps the postprandial at lunch and may have an effect also on the postprandial at dinner. So in early studies, when lixisenatide was shown, once daily, it was studied twice daily, et cetera, it looked like overall glycemic control was similar. I think it's certainly not the effect of lixisenatide, direct effect at dinner, for example, but it probably is just improvement with pre-meal glucose, improvement with glucose toxicity, just overall improvements in glucose that then help with the subsequent meals. But this is what we've seen with the data, significant improvement based on the basal bolus. It could also be that with the basal bolus, they're just not taking their insulin, and we're just not seeing that. What is your opinion for using Soliqua in patients with double diabetes, like type 1 diabetes and obesity? I haven't done it, but I do use GLP-1 receptor agonists in people with type 1 diabetes to manage their overweight and obesity. So I think, done carefully, I think it would be reasonable. They will still need prandial insulin, though. So be careful with that. But, I think it's probably easier to manage, quite frankly, a type 1 diabetes patient with, if they're on a pump or, especially if they're on AID system, just to manage them with a separate injection of a GLP-1 receptor agonist specifically for their body weight. I think I'd probably be more comfortable with that because there really isn't much experience with Iglar Lixi in people with type 1 diabetes. But if it was to be done, I think, you certainly would get, likely a reduction in the insulin dose, maybe at least no increase in body weight. But generally, my patients with type 1 that have sort of double diabetes are quite obese, and they're going to need, maybe a 10 or even 15% reduction in body weight. So I'm going to treat them with an agent like semaglutide or tirzepatide, to Mounjaro or Wegovy or Zepbound for us in the U.S. to really help manage the weight and have these done separately in people with type 1 diabetes. My opinion, others may have other opinions. I just don't have a study and I haven't done it.
Okay, thank you. What about somebody's asking if the patient's taking long-acting insulin?
Mhm.
Who are patients you're gonna switch to lexinotide, glargine, or add GLB with a once weekly?
Yeah,
Where to go?
Yeah, I think it depends on what my main goals of therapy are. So if I have a patient who really one of my key goals is to have significant weight loss, I'm going to go with a drug for weight loss. So I'm going to go with, semaglutide at high dose or tirzepatide, and that is just to really manage their body weight. But I think this is a bit of a different situation when we look at these studies. These are patients who are already on insulin therapy, who have, 10, 15, 20 years of diabetes, some of which don't even need any weight loss, and they're over 65. So this is a population where they're already on premixed, they're already on basal bolus, and we're trying to just simplify their insulin therapy. More than likely, they're very insulin deficient given this 15-year average duration of diabetes. Many of these patients, certainly in my practice, are the so-called phenotype of SID, or the severe insulin deficient diabetic patient, which even in the US is about 20%, and certainly in some populations can be as high as 40%. So they need insulin therapy. And I'm like, well, if I see data to show that one injection of insulin with lixisenatide can give me better results, either similar glycemia or better glycemia, but with weight gain mitigation or maybe weight loss, lower insulin dose, very importantly, less treatment burden, I'd much rather go to one injection. At the end of the day, if it doesn't work for some reason, you can always switch them back or again intensify a bit in those patients. So I think that's sort of my patient population. At the end of the day, I think we're, as you well know, I mean, we're going much more into kind of personalized and precision medicine, if you will, to the extent we can. So if someone needs to lose 40% of their body weight or something, they're either going to go to bariatric surgery or come into a retatrutide trial or something. And that's probably not the patient, but the patient who's already been intensified, is having issues with their regimen, needs simplification. I think this is a very good use of a medication like Soliqua.
Okay, thank you very much. I think it was very nice.
There is a last question, Dr. Frank.
Still question. I can't see it. Where is it? Yeah.
Yeah.
Let's see.
I can't see your question, yes. I don't know where you're hiding.
There is a Q&A in the Q. Yeah.
Can you see I don't have the Q&A. Yeah, it's not appearing. Could you read it, Yasser or Dr.?
Yeah, I've got the double diabetes. Let me see. If one injection to cover. Would you suggest that iGlarlixy may have cardiovascular benefits? You know what? I mean, certainly lixisenatide was shown not to have. There was a cardiovascular outcomes trial. It was very safe from a cardiovascular perspective. There have also been real-world studies looking at iGlarlixy, actually a publication recently compared to iDeglira, and showed some advantages, particularly in patients with heart failure. I would say, we've got very good data on cardiovascular benefits and with the long-acting GLP-1 receptor agonist. But I would also say that many of these patients are on SGLT2 inhibitors and are already on medications to improve cardiovascular risk. Additionally, these patients need to have their traditional risk factors, treated with antihypertensives, if appropriate, antiplatelet therapy, if needed, and in fact, in all patients with diabetes, a statin, and they need to make sure we have the sort of the guideline-based metrics for those cardiovascular risk factors as well. So I think in a patient, again, who my main goal is cardiovascular risk reduction, I may choose to go with a drug that's got proven cardiovascular benefit. But I would say, in a patient where that's not my primary goal, and particularly if they're already on drugs that significantly reduce cardiovascular risk, then I need to weigh things and see what's best for the patient. And I certainly would be comfortable using a drug like iGlarlixy that doesn't, has been shown anyway in in more real-world studies to potentially have cardiovascular benefit, but certainly has been proven not to have any cardiovascular risk. So I think that's important. Again, we need to individualize.
Sure. Yasser, any question you can see? Because
No, that's it.
okay, great. Then just again to thank you for the very elegant and really you answered many questions for us and our colleagues, and I wish you have a nice weekend. And I know it's Sunday. Thank you for joining us on Sunday, and enjoy the rest of the weekend.
Okay, well, thank you, and thanks everyone.
You.
Appreciate the invitation, and nice seeing everyone.
Thank you.
Bye-bye.